So, starting with the cases of missile and penetrating injuries. So, left is the axial non-enhanced CT scan of the non-enhanced CT scan, and it shows a small caliber, low velocity injury. A bullet fragment is present in the left temporal lobe with minimal adjacent hemorrhage. A narrow hemorrhagic tract is seen to be extending through the midbrain, with a second fragment embedded in the right temporal lobe. Regional subarachnoid and intraventricular blood is also noted. Right is the axial bone CT scan, and it demonstrates the tiny entry site in the squamous temporal bone with a focus of underlying intracranial air. So left is the axial non-enhanced CT scan, and it shows a large caliber high velocity injury with a frontal entry site and a wide oblique hemorrhagic tract that is seen to be extending to the left temporoparietal region. There is sulcal effacement and midline shift to the right. The right image is the axial bone CT scan, and it shows the frontal entry site and the left parietal fracture. Multiple bone and bullet fragments and foci of hair are also noted along the tract. Ricocheted metallic fragments are seen posteriorly away from the primary trajectory. Left is the axial non-enhanced CT scan, and it shows extensive hemorrhage along the small caliber mesial trajectory from right to left, crossing both the basal ganglia. Scattered subarachnoid blood and minimal intraventricular blood is also noted, along with the diffuse sulcal effacement and early transtentorial herniation. Right is the axial bone CT scan in the same patient, and it confirms the presence of intracranial bullet and bone fragments on the right near the entry site. Left is the axial non-enhanced CT scan in a 15-year-old male with a high caliber gunshot wound, and it shows diffuse brain swelling. Hemorrhage in the left occipital horn is also noted. Multiple small metallic fragments are present under the entrance wound in the left temporal lobe. The deformed bullet lies under the right parietal galea, where it ultimately lodged after losing velocity. Right is the Morke-Fellert scan, and it shows the large left temporal subgaleal hematoma with the extracranial and intracranial bullet fragments. Left is the bone CT scan, and it shows the blown out right posterior temporal skull fracture, marking the site of the exit wound. Right is the Morke-Fellert scan, and it shows the multiple extra and intracranial bullet fragments. This patient had a Glasgow Coma Scale GCS of 3 at the scene and expired shortly after admission. Further investigation disclosed that the patient had been shot in an argument over a drug deal. As 90% of people are right-handed, left-sided gunshot wounds are not often self-inflicted. So, this is a classic case of epidural hematoma. Left is the coronal graphic, which is showing the swirling acute hemorrhage from a laceration of the middle meningeal artery by an overlying skull fracture. The epidural hematoma seems to be displacing the dura inward as it expands. The right is the axial non-enhanced CT scan in a 47-year-old man with head trauma, and it shows classic biconvex, lentiform, uniformly hyperdense epidural hematoma in the right middle cranial fossa. Bone CT scan, which is not shown here, it disclosed a non-displaced skull fracture underlying the hematoma. Left is the coronal scan reformatted from the axial data, and it is nicely demonstrating the classic middle cranial fossa acute epidural hematoma. Right is the sagittal non-enhanced CT scan, which is reformatted from the axial source data in the same patient, and it shows the classic biconvex configuration of the acute middle fossa epidural hematoma, and it is present in all the three major imaging planes. Left is the axial bone CT scan, and it demonstrates a portion of a comminuted fracture about the pterion. Right is the axial non-enhanced CT scan in the same case, and it reveals a small yet classic biconvex epidural hematoma underlying the skull fracture. There is also a posterior falcine subdural hematoma, which is seen to be tracking along the tentorium and the superior sagittal sinus. Left is the axial non-enhanced CT scan, and it shows a biconvex venous epidural hematoma that is seen to be extending both below the tentorium as well as above the tentorium. Right is the axial non-enhanced CT scan in the same patient, and it demonstrates a biconvex venous epidural hematoma that is extending both above and below the tentorium. Left is the axial non-enhanced CT scan, and it shows an anterior middle fossa epidural hematoma. Right is the sagittal bone CT scan, and it shows a non-displaced linear fracture that crosses the greater sphenoid wing. Such epidural hematomas cross the sphenoparietal sinus, and they are usually venous, and they typically do not require surgery. So these are epidural hematoma variant cases. Left is the axial graphic, which is depicting different basilar skull fractures. It shows different basilar skull fractures that cross and may injure the important vascular structures. Note the linear skull fracture, which seems to be crossing the right transverse sinus. The lacerated sinus causes a venous epidural hematoma to accumulate. The injured sinus often thromboses, as is depicted here. Right is the axial non-enhanced CT scan in a 26-year-old man who fell 10 meters onto his head, and it shows a large left temporal lobe contusion. A small biconvex hyperdense fluid collection is also noted adjacent to the right transverse sinus. Left is the bone CT scan in the same patient, and it shows a diastatic fracture through the right lambdoid suture. Right is the sagittal CT venogram, and it shows that the transverse sinus is elevated and displaced anteriorly by a hyperdense venous epidural hematoma. Note that the venous epidural hematoma lies both above and below the site of dural attachment. Venous epidural hematomas commonly cross the dural attachments, whereas the classic arterial epidural hematomas, very rarely, they do that. Left is the axial graphic. It is showing that the dural venous sinuses at the skull base, the sphenoparietal sinuses curve around the greater sphenoid wing, and then they drain into the cavernous sinus. The clival venous plexus is usually septated, so the venous epidural hematomas in this location are typically limited. Right is the axial non-enhanced CT scan, and it shows a small biconvex epidural hematoma anterior to the left temporal lobe. Bone CT scan below shows a non-displaced linear fracture through the greater sphenoid wing. Left is the axial non-enhanced CT scan, and it shows a typical anterior temporal epidural hematoma. Right is the follow-up non-enhanced CT scan in the same patient 24 hours later, and it shows that the anterior temporal epidural hematoma is unchanged in size, but now appears mostly hypodense. This is not caused by rapid bleeding. It is most likely caused by decompression of the epidural hematoma into the lacerated sphenoparietal sinus. Left is the axial non-enhanced CT scan in a 19-year-old man with basilar skull fractures, and it shows a small biconvex epidural hematoma posterior to the clevis. Right is the sagittal CT venogram in the same patient. It demonstrates small clival epidural hematoma under the enhancing clival venous plexus. Left is the axial non-enhanced CT scan in a 57-year-old man and shows a biconvex epidural hematoma over the left frontal convexity of the brain. On the right, the coronal non-enhanced CT scan is shown which is reformatted from the axial data in the same patient, and it is showing the vertex epidural hematoma. Left is the axial bone CT scan in the same patient, and it shows a linear fracture that crosses the midline. Right image is 2 hours later image of the same patient, and the patient is now deteriorated. The axial CT venogram is showing the vertex epidural hematoma has enlarged, narrowing the superior sagittal sinus, which also appears somewhat irregular in configuration. The epidural hematoma now contains hyperdense foci, suggesting the ongoing acute hemorrhage into the epidural space. Left is the coronal reformatted CTV, and it is showing the vertex epidural hematoma is much larger and now crosses the midline. The superior sagittal sinus is displaced inferiorly from the calvaria, and it appears severely compressed. An empty delta sign is also present, suggesting that the superior sagittal sinus is at least partially thrombosed. Right is the sagittal CTV, which is nicely showing the expanding vertex epidural hematoma, which now appears to have two adjacent compartments. The venous epidural hematoma was evacuated at surgery, and the torn, partially thrombosed superior sagittal sinus was repaired. So coming towards cases of acute subdural hematoma. So left is the graphic image, and it shows the acute subdural hematoma, which is compressing the left hemisphere and lateral ventricle, resulting in midline shift. Coexisting cortical contusions and the axonal injuries are common in subdural hematomas. Right is the axial non-enhanced CT scan in a 58-year-old woman with head trauma, and it shows a classic case of subdural hematoma, which is seen to be extending over the left convexity and compressing the underlying subarachnoid space. The subtle hypodense foci within the hyperdense subdural hematoma are basically representing the unclotted blood, and they are at risk and the risk for rapid hematoma expansion. Left is the occasionally acute subdural hematomas are isodense to the underlying brain. Note that the acute subdural hematoma with mass effect, inward displacement of the underlying gray-white interface, and left-to-right subfalcine herniation of the lateral ventricles. Right is the more cephalid non-enhanced CT scan in the same patient again, and it shows the isodense acute subdural hematoma. The underlying sulci are completely effaced. Compare this appearance of the absent sulci with the normal appearing CSF-filled sulci over the right hemisphere. So continuing with the acute subdural hematoma cases, left is the coronal graphic, which seems to be depicting the thin acute subdural hematoma, which is layering along the falx and tentorium. Such acute subdural hematomas may be difficult to identify on axial images alone. Multiplanar reconstructions are very helpful in identifying the small, thin acute subdural hematomas. Right is the axial non-enhanced CT scan in a 31-year-old man with minor trauma, and it shows the subtle hyperdensity along the tentorium and the inferior falx near the confluence of the venous sinuses. Left is the coronal reformatted scan from the axial data in the same patient, and it shows the small acute peritentorial subdural hematoma. A small subtle convexity acute subdural hematoma is seen here and was not visible on the axial scan. Right is the sagittal reformatted image in the same patient, and it shows the peritentorial acute subdural hematoma and the subtle convexity acute subdural hematoma that was invisible on the axial study. Axial non-enhanced CT scan is seen in the left image in a 30-year-old man with head trauma, and shows a small mixed density acute subdural hematoma over the left frontal and parietal lobes. Subtle hyperdensity within the acute subdural hematoma was concerning for the rapid accumulation of the unclotted blood. The right image is the patient, same case, same patient, but it has deteriorated, the condition has deteriorated 5 hours later. This image was obtained 5 hours later. The acute subdural hematoma has expanded significantly, and there are multiple foci of hypodensity within the hematoma, which is indicating rapid bleeding. Also, the subfalcine herniation of the lateral ventricles is also noted. Left is the axial graphic, and it shows a typical subacute subdural hematoma. Inset shows the traversing bridging vein and developing membranes. These are often related to the relatively minor trauma in the elderly. Right image is the subdural hematomas decrease by about 1.5 Hounsfield units per day. By 7 to 10 days, blood in the hematoma becomes isodense with the cortex. By about 10 to 14 days, it is hypodense compared to the adjacent brain. The axial non-enhanced CT scan on the left side shows a right subdural hematoma that is isodense with the underlying cortex. Also, the inward displacement of the dots of CSF is also noted. Inward displacement of the dots of CSF in compressed underlying sulci. The gray-white matter interface is buckled inwards compared with the normal appearing left side. Right image is the bilateral. It shows bilateral balanced isodense subdural hematomas are present in this case, and also noted that both the gray matter and the white matter interfaces are inwardly displaced and the underlying sulci are compressed. A displaced dot of CSF is seen under the left subdural hematoma. So these are